Hi guys, this is Ada Ujai from MPPA Learning TV. This video is a video series on differential diagnosis of skin rash in outpatient setting. This video is a basic overview on concepts to help in differentiating diagnosis of skin conditions. Thank you for watching. Okay guys, we're gonna dive right in. Diagnostic approach. Important diagnostic approach or tools to consider include the following: history of ectopy, skin infection, occupational history, exposure to industrial pollutants, precipitants, associated symptoms, morphology, symmetry and distribution, color and configuration, appropriate diagnostic test for unclear clinical presentation or for skin disorders with poor clinical clarity. Case example. Mrs. Binturn is a 40-year-old African-American female presenting to your clinic for routine health visit with a chief complaint of heavy discoloration to the nape of her neck. She stated, I came in because I noticed my neck and my armpit area have gotten darker. So my question to you is, when you see this in your clinical setting, what important historical data or question would you include in your patient interview? Historical data. What important historical questions would you include in your patient interview? First, it is important to determine if there are any precipitating factors. However, in this case, it's clear that there is no discernible precipitating factor and that it is asymptomatic. It's just that the patient observed it on her own. It is important to inquire about history of systemic, chronic disease, and malignancies. It is also important to ask about any familial predisposition, presence of diabetes type 2, and presence of endocrine disorders such as Cushing's syndrome, Addison's disease, hypothyroidism. The list is really exhaustive. It is also important to inquire about itching and pruritus. This is heavily related to the presence of neoplasms. It is important to ask about medication or OTC/supplement use. Examples of medication that may cause hyperpigmentation of this presentation are nicotinic acid, OCP, systemic steroids, niacin, and bodybuilding supplements. Also, it is very important to note the presence of obesity, as obesity has been linked to hyperpigmented lesions. Morphology. Morphology is an important rudiment for diagnosing skin lesion. What is the morphology of a lesion? Morphology is akin to structure and form. Morphology just means what is the form or structure of the lesion. Morphology helps to identify if the skin is of a primary morphology or a secondary morphology. Within the medical spectrum, skin conditions are classified by primary and secondary morphology. Primary lesions are skin conditions that are present on the skin secondary to a disease process. This just means that when the lesion or discoloration is present on the skin, it is because there's a skin condition present. Secondary lesions result from tampering or manipulating the primary lesion. Examples are scratching, itching, and removing plaques. The following diagram depicts primary and secondary lesions. Get familiarized with the diagram because it includes the most common presentations. Can you describe this lesion? Based on the already prescribed diagnostic approach from the presentation, what morphology is this lesion? It is a primary lesion, best identified as a plaque. This lesion is not as a result of mechanical pressure or an extraneous stimuli, or scratching or itching. Distribution and symmetry. Distribution and symmetry is the next important tool in diagnosing skin lesions. Note any anatomical predilection. Determine if lesion is localized, widespread, or sporadic. Determine if lesion have symmetry, if it's asymmetrical or unilateral in presentation. Can you describe the distribution of this lesion? It is typically circumscribed to intertriginous folds, neck, antecubital fossa, popliteal fossa, and axilla. Color and configuration. Color is predicated by melanin, lipolysis, keratin, and hemoglobin. To be specific, color just means what is the predominant color of pigmentation. Configuration is concerned with how lesions are shaped. Is it coalescent? Is it linear or dermatomal? This diagram depicts configuration, that is, the standard configurations for skin lesions. It is important to get familiarized with it. So now, can you describe the color and configuration of this lesion? Based on the already prescribed diagnostic approach, what is the color and configuration of the lesion? The color and configuration of the lesion is the following. Hyperpigmented velvety brown patches circumscribed to the neck or axilla area. It does not have a distinct configuration. What is your probable diagnosis? Based on the prescribed diagnostic approach, active recall or critical thinking of likely skin condition, and the distinct clinical features per presentation, the probable diagnosis is Acanthosis Nigricans. Yay! Acanthosis Nigricans differentials. Differentials to consider with Acanthosis nigricans include the following. Seborrheic keratosis has a waxy stalk-on appearance. It is prevalent in patients greater than 30 years old. It affects males and females equally. Becker's nevus. Brown macules with indistinct borders, pigmented, and has a predilection for shoulders, chest, and back. Pemphigus vegetans. They are vegetative plaques in flexural areas and intertrigal folds. Vegetative just means coalescing and granulomatous or fibrotic. It's prevalent in teens. Lichen simplex chronicus. They are pleuritic plaques with erythema circumscribed to the neck, extensor surfaces, extremities, and genitalia. It is prevalent in patients with history of atopic disease, xerosis, which is dry skin, and common in a subset of elderly patients. Management principles for Acanthosis nigricans include the following. Diagnostics. Diagnostics include fasting blood sugar, lipid levels, plasma insulin level, TSH, chemistry profile, and CBC. It is very important to rule out malignancies in patients with pruritus, age greater than 35, and non-obese patients. Treatment modalities comprise treating underlying disease process, discontinuing offensive drugs, topical cherolytics, anti-hyperandrogenic therapies such as metformin, OCP, and weight and dietary counseling. Consultation with specialists for underlying endocrinopathy not suitably managed in outpatient setting is necessary. Also perform consultation for dermabrasion or laser treatment for bulky lesions or heavy plaques. Thank you. Thank you so much for watching. Please subscribe to our channel. Bye.